name is Mike Winters. Now, for those of you that have watched previous Critical Care Symposium and attended the symposia, you'll notice this year we're doing things a little bit different. Rather than a potpourri of topics in critical care pertaining to the care of our ED, critically ill patients, we're going to focus on just one topic. And that happens to be one of the most common critical care things we do in the emergency department. We perform endotracheal intubation and then we initiate mechanical ventilation. Now, despite the last decade of increasing boarding time, increasing number of intubations, and critically ill patients staying in the ED for longer periods of time on the ventilator, we actually do a poor job at teaching all of you ED mechanical ventilation. In fact, there's some studies in recent years by some EM critical care gurus, Susan Wilcox, Evie Marcolini, that demonstrate, despite this being one of the most common things we do in the emergency department, for our residents and faculty, they receive less than 3 hours annually on education regarding mechanical ventilation. So what we're going to do this morning is really bring us all up to date, current practice on really mastering ED mechanical ventilation. We're going to get things started with Dr. Allison on really how do we set the ventilator. Dr. Martinelli is going to provide us expert pearls and pitfalls on post-intubation sedation in our patients that are receiving mechanical ventilation in the ED. We'll then advance, take a step forward with Dr. Sutherland talking about alternative modes of mechanical ventilation. We'll then talk about a few pearls and pitfalls if someone on the ventilator that's boarding in the ED all of a sudden becomes hemodynamically unstable. And then let's just say you have a patient that you've intubated and has been in your ED for hours, and they've actually resolved the indication that you intubated them for. Dr. Hu is going to bring us home on how to safely extubate patients in the emergency department. So a ton of pearls, pitfalls, and education this morning, all with the goal of having us master ED mechanical ventilation. So without further ado, I want to welcome a good friend to get us started, Dr. Michael Allison. Dr. Allison is a graduate of our EM/IM critical care program here at the University of Maryland. Following his completion of our 6-year track and his triple board certification, Mike now works at one of the hospitals just south of the medical center here, where he is the assistant director of the medical intensive care unit at Ascension St. Agnes. Mike, thanks so much for joining us here at our Critical Care Symposium. So looking forward to you educating us on what we need to do to start mechanical ventilation.
Well, thank you, Mike, for the invitation and the honor of being here and speaking with you all about mechanical ventilation. So I've got a poll everywhere up, and let's see if we can get a couple of responses as folks log in. So, like Mike said, we are experts at the airway in emergency medicine. And I think if anything the past year, we've been able to deftly adapt our intubation practices, taking care to avoid the potential for aerosolization. And it's really a feather in our cap that we are the experts at the airway. But I think when you talk with emergency physicians, oftentimes you don't hear the same level of confidence in their expertise in mechanical ventilation. And so that's why we're talking here today. The past year proved a couple of things. One, early in the pandemic, Italy and New York were getting overrun with patients. We were focused on doubling ventilators, increasing ventilator capacity. But with retrospect and looking back at this past year, we realized the real critical resource were the providers, the people who know how to manage the ventilator to place patients on mechanical ventilation, initiate and optimize mechanical ventilation. So with that regard, I want you to have a better relationship with mechanical ventilation after we are done talking today. A couple of polls here. I wanted to get a pulse of the audience and see who has a respiratory therapist with them in the emergency department as they're caring for critically ill patients. give it a couple more seconds. In case we're having difficulty with pull everywhere, I'll just keep moving. And the reason I ask that is because a lot of times we defer to the respiratory therapist. And instead of deference, we need to partner with our respiratory therapists, come up with protocols together to manage these patients well. Next poll, my favorite mode. All right. So as we go through these polls, we'll lead into the objectives for the talk. So I have 3 objectives, and hopefully by the end of this discussion, you'll take away 3 things. 1, a way of choosing your initial mechanical ventilator settings. There's so many different modes and options. The choice, I think, is going to be easy, and we'll review that choice. Second is going to be settings. In the past decade, almost 2, we've been focused on lung protective settings on the ventilator. I want to review that and affirm that choice of ventilator strategy, but I also want to talk about our oxygenation strategy as emerging literature has put that into focus. And lastly, you're not excited about a new ED bundle, I'm sure, but I wanted to review what I think and I consider the best emergency department mechanical ventilation literature showing that a bundled approach to post-intubation care actually can save lives. So let's begin by talking about modes. And CMV, you might see CMV, continuous mandatory ventilation. This is the way ventilators were designed, to mandate that if I set a respiratory rate of 15, that you will get 15 breaths per minute, no fewer and no more. So that's fallen out of favor and is now been replaced by assist control. Some ventilators will still use that CMV term, but assist control ventilation allows you to be more comfortable with the ventilator, allows patients to actually breathe over a set rate. SIMV, synchronous intermittent mandatory ventilation, is a mode that you'll hear about a little bit later on this morning. And spontaneous ventilation, thinking about pressure support and volume support modes of ventilation, round out your choices of modes of ventilator. AC is used in the majority of mechanical ventilation studies because it's available and universal on nearly all ventilators, no matter where you are. So becoming comfortable with ACVC, as you'll hear, is what I would recommend. With SIMV, you're going to hear that in the sedated and paralyzed patients, this is going to be the same as AC at first. It allows for some patient spontaneous effort. It was built as a weaning mode and is not going to be our go-to in the emergency department. And our spontaneous modes, certainly as we're sedating, paralyzing our patients, these are not good for the patients who aren't awake, who are in respiratory failure. Other modes you'll hear about: APRV, high flow oscillatory ventilation, and NAVA ventilation. So after you choose your mode, you have to choose a type of breath. And there are 3 types of breaths that I want to discuss today: volume control, VC, pressure control, abbreviated PC, and hybrid modes. And depending on your ventilator, these can have different names. For instance, the Puritan Bennett is VC+, Servo is PRVC, Draeger is Autoflow, all doing very similar things with the ventilator, just different names. Let's start with volume control. And I want you to use this breath type. So volume control is going to be the breath that you're dialing in that volume. And remember, we're really concerned with the amount of volume that we're giving our patients. And so volume control makes sense to be the breath type that we're going to use. Why not pressure control? Their volume is not set. So depending upon the lung compliance, a COPD patient with very compliant lungs might have very high tidal volumes with the same pressure that you give an ARDS patient who has low lung compliance and might have smaller tidal volumes. So you cannot guarantee a minute ventilation with pressure control. It just takes a little bit more work and observation and monitoring. Then the hybrid modes. These are going to be less helpful for patients who have a lot of work of breathing, who might have dysynchrony, who might end up using the ventilator more and more. These hybrid modes are designed to give less and less support as the patient gives more and more effort. So in the emergency department, these aren't great options for our patients who are just intubated with respiratory distress. So our conclusions here, the potpourri of terms, all of the different modes and all of the different options, I would suggest master AC, VC for all your emergency department needs. Let's segue into settings now. And our settings, there are 4 cardinal settings. The respiratory rate and the tidal volume are our traditional ventilation settings. You've got PEEP and FiO2, which are going to be our settings to target oxygenation parameters. Let's start out with talking about ventilation. And for 21 years now, it's been 21 years since the famous ARMA trial by the NHLBI ARDS network on low tidal volume. And you'll recall, and you know, that we're setting a tidal volume based upon predicted body weight, which is based upon height and gender, not the patient's actual body weight. Despite knowing this, a lot of emergency providers are not initiating lung protective settings in the emergency department. Take this observational look at mechanical ventilation in the emergency department from 2015. These patients intubated in the ED, they looked to see if there was ARDS development within the first 5 days after intubation. Multi-center observational prospective study that found that of the patients enrolled, their mean tidal volume was 7.6 mLs per kg of predicted body weight. The real finding was, despite that mean being close to our lung protective settings or within our lung protective settings of 6 to 8 mLs per kg of predicted body weight, 43% of patients in this observational study had injurious, potentially injurious tidal volumes of greater than 8. So remember, in the emergency department, your settings stick. We did a study here at the University of Maryland, and we found that if the settings in the emergency department were not at lung protective goal, it took an average of 14 hours to get there once the patient hit the intensive care unit. And in the study I just mentioned, the majority of patients had little titration of their ventilator settings in the emergency department. So your settings are sticky, so make sure you're setting them right and getting that lung protective ventilation done. You know it, it's just a matter of implementing it. Now, aside from volume, you've probably been taught about plateau pressure, right? So if my plateau pressure, if I measure it and it's less than 30, that's all I need. I don't really need to worry about the volume specifically, right? Well, in a reanalysis of that classic ARDS network study, they looked at plateau pressures as a continuous variable. And is there one level below which is safe and above which is injurious? And clearly by this graph, you can tell no, there's not. That lower plateau pressures than 30 portend better outcomes, lower mortality. So pay attention to that plateau pressure, make it as low as feasibly possible, and you're going to achieve those low plateau pressures by adhering to lung protective strategies with regards to your tidal volume. So enough on ventilation. I want to spend a little bit more time today talking about oxygenation, and in particular, talking about FiO2 and the FiO2 that we set. Because it's no surprise to many of you watching that high oxygen levels and hyperoxia has been associated with some poor outcomes in the literature of late. Take this critical care trial looking at ICU patients with an expected length of stay of greater than 72 hours. Single center, and these patients were randomized to a strategy of normoxia, which was defined as a PaO2 of 70 to 100, and that was the intervention group, versus a control group of some relative hyperoxia, a PaO2 of 100 to 150. For those that weren't getting routine and constant arterial blood gas measurements, that corresponds to SpO2s of 94 to 97% in the intervention group and greater than 97% in the control group. Their findings: increased mortality with even that relatively small amount of hyperoxia, and a number needed to harm of 11. So that opened my eyes because that hyperoxia doesn't seem all that bad. Sometimes in the intensive care unit, I'm used to seeing patients come up set on 100% FiO2 and having a PaO2 of 200 or 300. So what's with this disconnect? And is there something that tells us what to do in the emergency department, because that literature, as I said, and I started, was ICU patients with long expected length of stays. But here's another observational study looking at patients in the emergency department. These are patients that once they went to the ICU were normoxic. So anyone who was hypoxic or hyperoxic in the ICU was eliminated from analysis by design. This observational cohort looked at patients and stratified them into 3 groups: a PaO2 of less than 60, the hypoxia group; a PaO2 of 60 to 120, which is the normoxia group, defined here; and a PaO2 of greater than 120, defined as hyperoxia for this analysis. And findings here, when they looked at 688 patients, mortality in the hypoxia group, 13%. The normoxia group, 19%. And the hyperoxia group of 30%. So this is correlation. This is not causation. This is observational in nature. This is not randomized. But this begins to paint a picture that maybe we're doing some things wrong by hyperoxygenating our patients immediately after intubation. And for those of you who are up to date and saw this study come out in the past month, the Hoticu Trial, handling oxygen targets in the ICU. It was a multi-center randomized trial looking at thousands of patients and randomizing patients to one of 2 groups: PaO2 goal of 60 or a PaO2 goal of 90. So both of these would be considered, I think, normoxic in our prior studies that I discussed. They looked at 90-day mortality, found relatively high 90-day mortality of 42% in both groups, and didn't have any statistical significance. So what do I make of these trials? Observational in nature, some of them randomized, some of them showing harm to hyperoxia, and some of them showing no difference between different levels of normoxia. I would hope you take away that oxygen is the new tidal volume. We're going to be setting both low. So I think the time has ended for us to intubate, start mechanically ventilating our patient, and keeping them on 100% oxygen, an FiO2 of 1.0. We have to do better for our patients. So let's review some of these settings that we've talked about. I told you about the cardinal settings, the 4 cardinal settings, and I added a 5th one here, which is flow. And I make sense of patients coming into the emergency department and stratifying them into 2 major groups of acute respiratory failure: an injury pattern, and we've all become accustomed to this pattern of acute hypoxic respiratory failure in the past year due to the pandemic. And then obstructive patients. These are our patients with acute exacerbations of COPD or acute exacerbations of asthma. So let's go through the differences on how you'll set your mechanical ventilator for these patients. In the injury patient, we're setting a respiratory rate that's a bit higher than you might be otherwise comfortable with or thought about. And the reason here, we're setting low tidal volumes. We want to keep their minute ventilation adequate, so a slightly higher respiratory rate for this group. Conversely, that obstructive group, low respiratory rates, right? I favor 10. If you look at some literature, it can go up to 16. And in order to ensure these low respiratory rates, you might need to sedate your patient. So a plug for the upcoming lecture on sedation in mechanically ventilated patients in the ED. So stay tuned for that. How about tidal volume? Across the board, we're going to be looking at our lung protective settings. In our injury patients, I would go on the lower side of this and get them as close to 6 mLs per kg as you can. Whereas in the obstructive patients, being a little bit more permissive, since our respiratory rates are so low, allowing them to have 7 to 8 mLs per kg of predicted body weight sounds like a reasonable place to start before you start adjusting. PEEP. For the injury patterns, I think, again, this year we've become a lot more comfortable with higher PEEPs. Setting a PEEP of 5 to 10 at the start is fairly common, but ramping that up above 10 centimeters of water is certainly reasonable to achieve your oxygenation goals. For obstructive patients, a PEEP of 5 centimeters water is a great place to start. How about FiO2? And here's the difference that I'm hoping that you'll take back to your next mechanically ventilated patient in the emergency department. Set that FiO2 at a reasonable level of 40 to 60%. And as you'll see in the bundled care that I'm about to discuss with you, have a strategy on how you're going to increase that FiO2 in step with PEEP. For flow, an injury pattern can take a flow of about 60 liters per minute. An obstructive patient, you could go higher on the flow, 70 to 90 liters per minute. High flow equals quicker breath, and a quicker breath equals more time for exhalation. So if your ventilator is one where you're not setting flow but I time, for injury pattern, you can have a reasonable I time. For obstructive pattern, you can decrease that I time. Flow increased, I time decreased. A word of caution here, patients that don't fit nicely into these categories where you can potentially see some risk management issues in the emergency department are patients with metabolic acidosis. Be mindful of these patients. Your DKA patients that you wanted to avoid intubation, but you had to. Your septic shock patients with high lactic acidosis. Your mesenteric ischemia patients who have a high respiratory drive. These patients, once you intubate and mechanically ventilate, you're going to need to provide them with a high minute ventilation. So respiratory rates are high, and your initial tidal volume settings might need to be more along the 7 to 8 mLs per kg of predicted body weight until you can make sure that you're adequately ventilating with a pH, say, of greater than 7.20, rough number, and greater. And the worst thing that can happen is you underventilate these patients with metabolic acidosis. You no longer have any respiratory compensation, and the next thing you know, you have an ED cardiac arrest or a post-intubation cardiac arrest. Let's segue into bundles as our final portion of this journey in the morning. And this is the study that I referenced before. It's the Love ED trial, and you heard me say that I think this is the best emergency department mechanical ventilation trial out there to date. They looked at patients intubated in the emergency department and gave them a lung bundle of 6 steps. They did a quasi-experimental design, so it was a before, they had an intervention period, and then they looked at the after that intervention of this bundle in the emergency department. They had a primary outcome of looking at ventilator-associated conditions. That's the CDC's new term for VAP, and development of ARDS. Secondary outcomes of your typical metrics, length of stay, ventilator time, and outcomes such as mortality. Here are the 6 steps that they did in their newly intubated patients in the emergency department. First, set a lung protective tidal volume, and they gave a range actually of 6 to 8 mLs per kg of predicted body weight, going for 6 if that patient has an injury pattern. Check a plateau pressure. In prior studies found that plateau pressures were infrequently checked in the emergency department. So checking a plateau pressure, and your respiratory therapist can show you how to do this, and you could partner with them on this, and making sure it's less than 30. If that plateau is greater than 30, turn that tidal volume down a little bit. They set a PEEP at one of 3 levels. BMI less than 30, you got a PEEP of 5. BMI greater than 30, you got a PEEP of 8. BMI greater than 40, you got a PEEP of 10 for your initial PEEP. Set FiO2. Their recommendation, a little bit more conservative than mine, going all the way down to 0.3 of FiO2 or 0.4 of FiO2 and titrate. That's 30% and 40% respectively. Setting a respiratory rate of 20 to 30 breaths per minute, with the exception of the obstructive patients who can be ventilated with a lower respiratory rate, as we discussed. And then head of bed. This is your ventilator-associated pneumonia or VAC prevention. Head of bed up. Earlier studies showed that most patients ventilated in the emergency department were flat almost the entire time they were there, placing an OG tube, preventing that potential for aspiration. So their results, pretty remarkable. They achieved the goal of post-intervention having set tidal volumes being lower. They decreased ventilator time, decreased length of stay, decreased ventilator-associated conditions, and even demonstrated a mortality difference of 34.1 to 19.6%. Pretty remarkable. Again, it suffers from all the limitations of a before and after design, but the bundle put in place showed improvement in all the metrics that they wanted to measure. So what I think you should do, this is going to be that partnership between your ED leadership, your respiratory therapy, and setting a culture where these things are checked off in sequence after a patient is intubated and mechanically ventilated. Make it the routine. Don't make it the exception. When you make it the routine, these things will be implemented and your patients will have better outcomes. So a few take-home points as we bring this home. First, when you're choosing your ventilator settings, ACVC. That's going to solve nearly all of your mechanical ventilation problems in the emergency department. Dr. Sutherland later on will discuss a couple of different options, but I would say choose ACVC and let him convince you why you shouldn't. Settings. Lung protective settings, we know that what they should be. We know how to calculate it, but we don't do it all the time in practice. So remember those lung protective settings. And now I want to add a second wrinkle in there, which is lowering your FiO2. Make sure those patients aren't getting 1.0 of FiO2 or 100% oxygen for any long duration of time. I've shown you some of the data on the dangers of hyperoxia and how those can portend bad outcomes. Lastly, the best way to approach your ED patient intubated and mechanically ventilated is set up that bundle. Don't wait. Partner with your respiratory therapist. Together you can enact all those 6 steps, and what you'll see, I hope, are improved outcomes in your mechanically ventilated patients that you're intubating in the emergency department. Thanks for your time this morning. I'll turn it back to Mike.
I took home are the fact that what we set in the ED matters, and that it goes when we transport patients, even if they're hanging out with us for 8 or 9 hours, when they get upstairs to the ICU, things that we set on the ventilator are continued for many, many hours into their ICU course. So I think that's a really important take-home pearl. And what you've talked about and setting that lung protective settings based upon predicted body weight, critical. And then I really like the pearls about decreasing the FiO2 and not simply leaving patients indefinitely on 80, 90, 100%, and really driving up that PaO2. So those are incredibly important pearls, and it's just a great way to get us started. So my thanks for being here at our Critical Care Symposium.
Oh, thank you, Mike. My pleasure.